Hello everyone, and welcome to our weekly podcast brought to you by VJOncology. As it is Oesophageal Cancer Awareness Month in the UK, we will be covering the latest on oesophageal cancer this week. To begin, with Yelena Janjigian from Memorial Sloan Kettering Cancer Center, who discusses the 5-year follow-up results from the Checkmate 649 trial of first-line nivolumab with chemotherapy versus chemotherapy alone with advanced non-HER2 gastroesophageal junction Oesophageal adenocarcinoma.
So Checkmate 649 is a large phase 3 study that answered the question whether a combination of chemoimmunotherapy can improve survival and other clinical factors of efficacy, such as response rate and progression-free survival in first-line patients with metastatic gastric and gastroesophageal and esophageal adenocarcinoma. It's a large study, and it's first of its kind to include esophageal adenocarcinoma patients together with stomach cancer, because biologically those cases are the same from their molecular profiling and other features, similar enough that they should be approached the same in metastatic setting. And we demonstrated that all biomarker-selected patients, including by PD-L1 CPS score, improved with treatment with nivolumab. And what's important to note is that we improved overall response rate, progression-free survival, and overall survival in combination with nivolumab plus standard chemotherapy, which is FOLFOX. FOLFOX is a doublet chemotherapy that's used worldwide for treatment of gastric cancer, so it's a very approachable regimen to use for patients and for the clinicians worldwide. And the 5-year survival continues to impress folks. We have long-term survivors in patients with stage 4 disease in a global phase 3 study. So be able to update the survival curves over and over again, showing separation in the survival curves. And approximately 17% of patients who are alive and well 5 years out. As you know, that microsatellite instability is a very rare event in gastric cancer. It's only 3% of the population in this study. So beyond microsatellite instability, beyond high PD-L1 overexpression, there are cohorts of patients that are alive with this disease long-term, and that's the important update of Checkmate 649 study, which has changed practice for patients globally. Before the study was published, the median survival overall survival that was quoted for the study or for the other studies for this population was less than a year. So here we surpassed the 1-year mark and improved outcomes for our patients, and that's great to see.
Next up, with Berend van der Wilk from the Erasmus MC Cancer Institute in Rotterdam, who comments on the SANO trial, a randomized trial investigating the efficacy of active surveillance versus standard resection after neoadjuvant chemoradiotherapy for locally advanced esophageal cancer.
We saw that nearly 1/3 of the patients who undergo neoadjuvant chemoradiotherapy followed by a surgical resection of the esophagus, that they had a pathologically complete response, which raised the questions whether or not all patients needed esophageal resection, or should we be willing to implement an organ sparing active surveillance strategy for a subset of patients who responded very well to neoadjuvant chemoradiotherapy. Therefore, we performed the SANO trial. And in the SANO trial, we did a multi-center non-inferiority stepped wedge cluster randomized trial with 12 Dutch hospitals, and we included patients with locally advanced esophageal cancer. And afterwards, we randomized them between neoadjuvant chemoradiotherapy followed by active surveillance or neoadjuvant chemoradiotherapy followed by standard resection via this step wedge cluster randomization. And with the active surveillance, we performed frequent clinical response evaluations. And if patients had a persisting complete response, then they proceeded in active surveillance. And if they had a residual tumor during active surveillance, then we performed surgical resection. So we included 309 patients in total, and we compared for the primary outcome, we compared overall survival, and we had also a few secondary outcomes, which included the disease-free survival, health-related quality of life, the rate of distant metastasis, and also the post-operative complications after esophageal resection. So after a minimal follow-up of 2 years, we included 309 patients who had a clinically complete response. And patients with a clinically complete response had no tumor 6 and 12 weeks after completion of neoadjuvant chemoradiotherapy using response evaluations, which consisted of endoscopy with bite-and-bite biopsies, ultrasonography, and PET-CT scan. And after inclusion of those 309 patients, we saw that overall survival after 2 years was non-inferior for active surveillance compared to standard surgery. We saw that also the disease-free survival was comparable between both groups when we took the whole follow-up into account, which was the same for the overall survival. And we saw that approximately 40% to 50% of the patients who underwent active surveillance eventually needed an esophagectomy. Those patients who needed an esophagectomy because of local regional residual disease could be operated safely and timely, because we saw that the operative outcomes of patients who underwent postponed surgery, those results were comparable to the patients who underwent standard surgery immediately in terms of radical resection rate, in terms of blood loss during the operation, etc. And also we assessed all post-operative complications for those patients, and we saw that those were comparable as well, actually, between the prolonged or the postponed surgery group and the standard surgery group. We saw that the patients who underwent active surveillance developed distant metastasis in 43% of the patients group. Compared to standard surgery, this was 9% higher, so it was 34% in the standard surgery group, although this was not statistically significantly different. But I think we should recognize that it's numerically higher, which we need to assess further in the long-term results. Finally, we also assessed the health-related quality of life between both groups, and we saw that the short-term health-related quality of life of patients undergoing active surveillance was significantly and clinically relevant improved compared to those patients undergoing standard surgery. And we tried to assess how many patients were avoided an unbeneficial esophagectomy, and we assessed that nearly half of the patients avoided an unbeneficial esophagectomy if they underwent active surveillance because of either prolonged clinical complete response or because of early distant metastasis, which were most probably already present subclinically. Therefore, we concluded that the overall survival for patients undergoing active surveillance is non-inferior compared to standard surgery. That health-related quality of life for patients undergoing active surveillance is improved on the short term, and that nearly half of the patients avoids an unbeneficial esophagectomy. However, we should recognize that for instance, the rate of distant metastasis was numerically higher, although not statistically significantly different, and that for the definitive results, we also have to assess the long-term results, and we will assess them at the start of June 26 after a minimal follow-up of 5 years. So that's in short the SANO trial and the results of the SANO trial.
Following on, Kohei Shitara from the National Cancer Center Hospital East in Kashiwa, Japan, comments on findings from Arm A1 of the EDGE Gastro trial, which evaluated bambanelimab and zimberelimab with FOLFOX in first-line advanced gastric, gastroesophageal junction, and esophageal adenocarcinoma.
This is a phase 2 trial to test first-line chemotherapy with anti-PD-1 and anti-TIGIT combination. Interestingly, this TIGIT is modified with a silenced FC portion, which is different from previous other TIGIT inhibitor like tiragolumab by Roche or Merck compound. Because of this silenced FC portion, it mainly focusing on blocking of TIGIT without depletion of CD8 cells or Treg cells, and it more efficiently activate CD8 effector cells in preclinical study. So in this study, in total, around 40 patients were enrolled, and it showed a promising overall response rate around 65%, and the median PFS exceed 1 year. And there is a trend of a better outcome, especially in patients with PD-L1 or TAP score 5 or higher population. This is quite reasonable because of the expected higher TIGIT or related molecular expression in PD-L1 positive or higher population. And the most impressive aspect of this result is overall survival. A median exceed 26 or 27 months, which might be one of the longest median survival in second-line study for first-line study for HER2-negative population. And the safety profile was in line with that of chemo plus checkpoint inhibitor. So there seems to be no increase with a combination with TIGIT inhibitors. But to conclude the efficacy of this combination, we are waiting for top-line result of phase 3 STAR-221 trial, which currently comparing chemo plus TIGIT and the PD-1 combination versus chemo and nivolumab as a current standard of care. So let's stay tuned.
He also provides an overview of the Fortitude-101 study of the marotuzumab as chemotherapy in patients with FGFR2b positive gastric or gastroesophageal junction cancer.
We have some exciting or important presentation. First is bemarituzumab plus chemotherapy Fortitude-101, especially for FGFR2b positive population. FGFR2b positive was defined by 10% threshold, and there is some overlap with FGFR2 amplification. So this is a clearly fast study to test this molecule in phase 3 for gastric cancer. And that study met the primary endpoint, overall survival at the interim analysis. As already presented, it showed median survival more than 5 months difference with a hazard ratio around 0.61. However, additional 7 months follow-up somehow changed the result with attenuation of difference of overall survival with median less than 2 months difference and the hazard ratio 0.82. So it is very hard to conclude this study, but maybe we need to consider this final or follow-up overall survival as most important result. So in that case, to receive regulatory approval might be not easy, but it suggests at least some range of activity in this unmet need population. And currently, very importantly, another FGFR2b phase 3 trial is ongoing as a Fortitude-102, which combines chemotherapy, checkpoint inhibitor, and the nivolumab. And safety profile is in line with the previous report. Bemarituzumab induced eye toxicity or keratitis, but it is in line with the previous report. So anyway, it is not easy to interpret and not easy to conclude, but let's stay tuned for 102 study, which will be reported in the near future.
Finally, Ian Chau from the Royal Marsden Hospital in London discusses the results of the Skyscraper 7 trial, a phase 3 study investigating atezolizumab with or without tiragolumab in patients with unresectable esophageal squamous cell carcinoma that has not progressed following definitive concurrent chemoradiotherapy.
TIGIT is an immune checkpoint which is relevant in activated T cells, NK cells, as well as Treg. Tiragolumab is a human monoclonal antibody that targets against TIGIT and may have enhanced benefits when added to other immune checkpoint inhibitors such as atezolizumab. And in fact, in advanced esophageal squamous cell cancer, there does seem to be incremental benefits. So with that background, a large global phase 3 trial was conducted at Skyscraper 7. Patients who have completed definitive chemoradiation for esophageal squamous cell cancer were randomly allocated into 3 different groups. They will be followed by tiragolumab plus atezolizumab on its own, or just placebo. And the primary endpoints in this study, however, is investigator-assessed progression-free survival and overall survival for the dual checkpoint inhibition, tiragolumab plus atezolizumab versus placebo, but also the overall survival for atezolizumab alone versus placebo. as you would expect with a large study where 760 patients were randomized into these 3 groups, their baseline characteristics were well balanced. And what we observed is that the dual checkpoint inhibitions, in fact, did not result in any improvement in progression-free survival or overall survival. But when we look at the second treatment comparison of atezolizumab alone versus placebo, we observed a overall survival benefit with a hazard ratio of 0.69. So that's a 31% relative reduction in the risk of death. And that translates into over 10% absolute overall survival benefit in favor of atezolizumab. We also observed an improvement in progression-free survival, both by investigator-assessed as well as by independent radiological review board. So really, the atezolizumab was showing a clinical meaningful benefit in overall survival and progression-free survival after completion of chemoradiation. In terms of safety, we did not actually observe any additional safety concerns, although the dual tiragolumab plus atezolizumab did have a higher rate of side effects. So really, in conclusion, although the primary endpoint was not met in the Skyscraper 7 of looking at the dual immune checkpoint inhibitions, the atezolizumab monotherapy, for the first time in the last 3 decades, have shown a clinically meaningful improvement in survival, overall survival, and progression-free survival after definitive chemoradiation for esophageal squamous cell carcinoma.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this podcast, please leave a review and subscribe on your favourite podcast app, including Apple, Podbean, and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology and join in the conversation, and visit VJOncology.com for the latest updates in the field.